Olá pessoal, tudo bem com vocês? Sejam bem-vindos a mais um OFT-CAST. É um prazer estar aqui para mais um episódio muito bacana com um convidado internacional. Na verdade, é um convidado que já participou com a gente durante a Braskers, o Dr. Dan Reinstein. Ele que é um dos grandes nomes da cirurgia refrativa mundial, conhecido no mundo todo por ter desenvolvido muitas técnicas e ser pioneiro, por exemplo, na técnica do Presbyond. E o Dr. Dan vai estar conduzindo um curso aqui no Brasil em agosto, um curso de cirurgia refrativa muito bacana. A gente vai discutir aqui, juntamente com o meu colega brasileiro, Dr. Fauze Abdulmassih, uma grande referência em cirurgia refrativa também, diversos tópicos interessantes em refrativa, como Lasik, Smile, Presbyond, tirar muitas dúvidas de muitos colegas aí que operam refrativa com essas duas grandes referências. Nós vamos fazer esse episódio em inglês, pessoal, vai ter legenda no YouTube, é só ir lá para quem não tem muita familiaridade com a língua. So, before we begin, we would like to thank ZEISS for their support in making this episode possible. Without this collaboration, this content wouldn't have been possible. So today, we want to welcome two leading figures in refractive surgery, Dr. Dan Reinstein and Dr. Fauze Abdulmassih, my fellow Brazilian colleague. Dr. Dan is joining us from London, so welcome, Dr. Dan.
Thank you.
And Dr. Fauze Abdulmassih, my colleague from Brazil, welcome.
Thank you, Bernardo.
We will be discussing some topics in refractive surgery, including Lasik, Smile, Presbyond, and I would like to start with a question to Dr. Dan. We know you have a strong preference for Lasik and Smile over PRK. Could you explain the advantages of these techniques beyond visual acuity recovery? How do Lasik and Smile offer better value, fewer returns, and more referrals for you? So it is an important topic for Brazilians that likes doing PRK. So this is the first question then.
Yeah, it's a very interesting question. It's interesting because Brazil and Italy are the two countries where PRK is, let's say the most common refractive surgical procedure. So why don't we start with thinking about that? Why, out of 168 countries, are there only two that prefer PRK? Why do the other 166 prefer lamellar surgery? In other words, the majority of countries do not prefer PRK. And there are many reasons for this. And, I have to start by saying that there's nothing wrong with PRK. It's, it's fine, it works. But the point here is that it is not the preferred procedure by a patient if they had the choice of being treated by a lamellar surgery or a surface procedure by a surgeon who has equal skill in both procedures. That's the point. If you don't have the skill set for LASIK, you should definitely be doing PRK. No question about it. And please do PRK. If you're going to train yourself learning on the job in LASIK and Smile, it's better you continue doing PRK. So you're right. In terms of complications generated by the surgeon, you have to have much more knowledge to do a lamellar procedure. But in terms of complications generated by the patient, PRK is much worse. Because PRK is a wound that's open for several days. And the probability of infection is 10 times higher with PRK than it is with lamellar surgery. The susceptibility of that cornea forever to UV exposure is an issue. Once you remove Bowman's, we know this, there are several studies supporting what I'm about to say. But once Bowman's is gone, a cornea is susceptible to UV exposure to develop haze forever. Late haze is a well-known phenomenon. One of the very early studies in the 90s done in Sweden showed that refraction, the average refraction of the PRK population, shifted from winter to summer. And you can only do that study in Sweden and Norway because they have 6 months of dark and 6 months of light, right? So they found that during the 6 months of light, where there's no dark, that the refraction actually became more myopic during that time. And that was because of subepithelial stromal deposition, neostroma, if you like, which if it's organized, it's transparent and you don't see it. But if it's disorganized, it's called haze. And during the winter, that haze or neostroma would diminish, and then there would be a hyperopic shift. So, you know, PRK is actually the least physiological procedure, because when you remove stroma and then you oppose stroma to stroma, that's very physiological. But when you remove the epithelium, remove Bowman's, and now you have epithelium sitting on stroma without Bowman's, that's not physiological. So if you look at the science behind, I have a lecture, which if you like, I can put a link up here on all of the science. It's a 30-minute lecture. It's on all the science behind PRK and surface procedures and when they are indicated, because sometimes they are indicated, right? So, I mean, for example, you have a central scar from a previous Pseudomonas ulcer from your corneal contact lens wear, and you're a -5, and you measure the scar with OCT, and the scar is, I don't know, 100 microns deep. Well, great. You know, do a 7mm optical zone, whack out the scar at the same time as you whack out the refractive error. Fantastic. That is an indication for PRK. If you have a recurrent erosion syndrome, then fantastic. You can take care of the refractive error and the daily pain in the middle of the night with one procedure. Awesome. That's an indication for PRK. But for example, corneal thickness is no longer an indication for PRK. It used to be in the microkeratome days when we had less control over what flap thickness we were going to get. But now that we can make flaps with a femtosecond laser, particularly the Visumax, you can make 80 micron flaps. It's the only femto out there that allows that because it's the only one with the highest precision to allow that. But if you make an 80 micron flap, that's 50 microns of epithelium and 30 microns of stroma. So if you know how to put back that flap without microfolds, which, like I said, it's not a mystery, it's just a technique. And it's a well-tested technique. And, you know, we've published 14,000 eyes showing that you can have 0 microfolds in 14,000 eyes if you use a specific replacement technique. You don't ever have to do PRK because of corneal thickness, because 30 microns of stroma is not the decider as to whether you can do a procedure or not. Yeah. I mean, okay, if you have a 440 micron cornea, you might be a little short of stroma to do your -3, maybe. But what I'm just saying, you know, in general terms, PRK is no longer necessary for corneal thickness. And the other thing is this form first, or, you know, questionable keratoconus, subclinical keratoconus. I disagree with the idea that if you have a suspicious cornea, you can do PRK. I disagree with that. Because if we had a proper study that was properly done, where you would put an ICL in one eye and did PRK in the other, I predict, we don't have it, but I predict that the safety of the ICL would be higher over time. Because some of those eyes that had PRK on top of a questionable cornea would develop ectasia. Whereas none of the eyes with an ICL would develop ectasia, for example. Of course, everything I say has to be couched in terms of you're a skilled surgeon in that procedure. Like if you're not a skilled surgeon, then you shouldn't be doing any procedure. So everything I say is to do with skill already acquired. And I mean, you know, we were talking earlier offline. Fauze came to our London Vision Clinic course in London. You know, we have set up a course which in 4 days goes through the granular theory of flap repositioning. You know, a lot of people talk about flap repositioning as, you know, Lasik is 7 steps. You put the speculum in, you put the suction ring on, you cut the flap, you lift the flap, you do an ablation, you put the flap back, you take the speculum out. Well, put the flap back is a 1-hour lecture. 1 hour on how to put a flap back. Once you understand flap repositioning at that level, it makes Lasik easy. And I mean, would you agree, Fauze? I mean, you know, if you can do that, why would you torture yourself? Forget about the patient. Why would you torture yourself with PRK? Having to see the patient over a period of a week and then months and then the steroids and then the haze and the mitomycin C and it's a nightmare having to manage PRK post-op in some cases. So yeah, that is my short answer to your question.
Yeah, I do agree. I just would like to point out a couple of things. The first one, it's actually your course, which gave me a lot of confidence for doing LASIK and how to proper do it to deal with not complications, but situations in which the final visual acuity might not be the ideal one. So this is a very good point because for everyone who wants to take a step forward and be a better refractive surgeon, specifically for LASIK surgery, should do the course because the LASIK day, it is truly amazing. And the other point I would like to make is in Brazil, we don't have optometrists. So we have to do our pre-ops and post-op visits. And this is something that usually we do not take account of. But we have to see PRK patients a lot more in our practice. Even though they are healing properly, sometimes they need more visits to our office. And as our time matters and we don't have optometrists, LASIK surgery, it's actually very good for our practice because we do less visits and we actually get more referrals because LASIK patients, they are very thrilled about how fast they recover vision. So that's my 2 cents on the point.
So, very nice answers. Now I want to add a question for Fauze about SMILE. We know that the number of patients undergoing SMILE procedures has been growing worldwide, with over 10 million eyes treated nowadays. How do you see this trend on a global scale, Fauzi? And what are the main benefits of SMILE compared to LASIK? And in which situation would you choose SMILE over LASIK?
I think this question it's mainly about myopia because hyperopia it's starting right now in the market for only a couple of years. But regarding to myopia, I think SMILE procedure or lenticle procedure, it's going to have more and more share for surgeries, especially because more platforms are coming into the market and the procedure it's getting more well known, especially away from Asia and Europe. In Latin America, more and more physicians and doctors are doing lenticle procedures. So I do think that we might see an increase in lenticle, and of course, Smile should be the best one because it was a pioneer, and it's some years in front of other platforms. But I do think that we should see a lot of more lenticle procedures, and of course, it has some benefits because we don't. It's a flapless procedure, so we don't have a flap. LASIK, it's a very, very, very good procedure, but if we can give a better, as good as of a visual recover as LASIK without the flap, I mean, why shouldn't we do it? So I think that's the main reason why we should do Smile instead of LASIK in some patients. Of course, there are some good candidates for LASIK regarding of age or refraction, but yeah, I do think that Smile has a very very nice profile of for treating patients. I would like to hear a bit more about it from Dan.
Yeah, I mean, my view on this is more to do with selecting the ideal procedure for each patient, each eye, if you like. I think we can say Smile is better because it doesn't have flap, but LASIK is better because the visual recovery is faster. You can do customized treatments. You can do extremely low prescriptions with LASIK, which is very hard to do with Smile. With Smile, the minimum cap is 100 microns. So if you can make an 80 micron flap, then actually you could treat higher myopia with LASIK than Smile. In other words, I can sit here and give you probably the same number of advantages of LASIK over Smile as someone can say of Smile over LASIK. Equally, I can talk for England, as we say here, on complications of Smile and complications of LASIK. There are complications that can occur with Smile that could never occur with LASIK. So, I'm a little bit careful about saying Smile is better than LASIK, like a general term. I would just say Smile is better than LASIK for this patient. And in terms of outcomes, this is very interesting because if you look at the literature, there are papers that say that Smile has better outcomes than LASIK. There are papers that say that LASIK has better outcomes than Smile. And there are a few publications that show that LASIK is the same as Smile. Now, just think statistically. What's more difficult? To do a study where you find the two procedures to be different, or to find a study where the two are the same? Which is harder to achieve? It's harder to achieve the same, technically, because it's less likely that they will be the same than that one is better than the other. That's more likely. It's more probability. So the same is 1 point, whereas better or worse is 4 points. One can be better or worse, the other one can be worse or better. So what we find in our practice, and if we look at myopia up to -7, the results are identical, like identical between LASIK and Smile. There's no statistically significant difference. However, in the very high myopia, we found that Smile is a little bit more precise. It's more likely to achieve 20/20 in one treatment. And that's easily explained by the fact that LASIK is a time-based procedure. The ablation takes place over time, and the longer the ablation, the more time there is for variables such as hydration, drying, eye movements, tracking. All of this stuff can happen during a -9 ablation. Whereas in Smile, the amount of time it takes to cut a -2 lenticule is exactly the same as a -10 lenticule, because it's this surface and that surface. It's further apart, but there's still two interfaces, and it takes the same amount of time to cut both. So there is no time variable in SMILE. Yeah. So there's an example of a superiority. However, having said that, because the cap minimum is 100 microns, you're basically wasting 20 microns of stroma that you could have used for correction if you did LASIK. On the other hand, SMILE induces less spherical aberration within the same optical zone as LASIK. Even the most optimized LASIK on the planet, still SMILE induces less spherical aberration. So then it depends on pupil size. Someone has a very small pupil, it doesn't matter. Someone has a larger pupil, well, it really does matter. So then SMILE is better. So do you see, I'm like running around the table here like a jackrabbit. It's not that simple to say this is better than that, is the way I would look at it. And I would say that effectively, if it's possible to condense everything I know about LASIK and SMILE and presbyopia correction into 4 days, then it's not a lot of information. Okay, it's just not. And what's interesting is how few people out there have had formal training in refractive surgery, and that's because, like me, when we started this in the 1990s, when you guys were, playing in the schoolyard with your little soccer balls, or in the street, but listen, this is old, this stuff, but none of us were trained. We all taught ourselves. And so the beautiful thing about your generation, and this is why I find it so exciting to teach, is that I know that if I can categorize and systematize what I do, and my outcomes are, I would like to say second to none. Yeah, which means there are other people the same, but no one better. Why? Because I've spent 30 years optimizing this and measuring my outcomes, and I have 1-year follow-up on all of the patients I have ever treated, but for the 10% who we lose so far. 90% of our patients have follow-up in our clinic, so at 1 year. So, I really have taken the trouble to optimize everything we do with protocols. And if we can then condense this into explaining it in 1 day, LASIK, to people of your age who, it's wonderful, right? It's a template. And the way I like to look at, my life is, the more people that I can help do it the same as I do, the better for everyone. Because I went through the trenches. I had lots of complications. I had lots of microfolds when I was growing up. I had lots of problems that I had to deal with. Epithelial ingrowth and this and melts and CTK and all these things that we didn't even know what they were talking about back then. But that doesn't happen anymore, right? I go to work every day now. I literally have zero anxiety. I had a patient, right now I have a patient who I enhanced a month ago. A week later, he went to France. He called the clinic with some eye pain. We know he has basement membrane dystrophy. We said it's probably a recurrent erosion. He then, about 4 or 5 days later, said, I can't open my eye. I thought, well, it still sounds like a recurrent erosion. Go and see an ophthalmologist. The ophthalmologist put him on a bandage contact lens and put him on, I think he gave him moxifloxacin. Yeah. And then a day later, he took the contact lens out and stopped the moxifloxacin because he thought he was allergic to it, because his eyelids got swollen. Well, he came to me 4 days later, couldn't open his eye, super red eye. The guy had an infiltrate and no epithelium on his flap because he had a full erosion. And this is something which, should have been recognized early and managed early. I got him a week later. So now I've got this, thankfully it's peripheral, infiltrate. But I'm getting back to my point here. I look at this horrendously angry eye with the flap now moved, no epithelium anywhere, end growth underneath. It's a mess. And my pulse doesn't even change. I'm totally calm. I'm like, oh, okay, okay. All right. Right here at the slit lamp, I removed all the epithelium. I recessed the epithelium from outside of the flap. Right here, with on the chin with anesthetic. I repositioned the flap perfectly. I put a bandage contact lens in. I know it's a little bit controversial with infections, but I do that. And I gave him broad spectrum antibiotic cover, including steroid, which is also controversial, but there's logic to what I'm saying. We could discuss that. And he's getting better. So again, if you know what you're doing, there's no anxiety. And so LASIK, PRK, SMILE, ICL, clear lens exchange, cataract surgery, it's all about the knowledge, and now nowadays there's really no excuse for not having all of the knowledge, because it is actually there. 20 years ago, even amongst experts, we completely disagreed about flap repositioning technique, about this, about that. What's DLK? There was like a list of 20 things that cause DLK. It's basically one thing that causes DLK, actually, like clinically significant DLK. And the rest are like, doesn't matter. We know all this now. So now is the time where formal training in refractive surgery is the way. And you guys are very lucky, because you can, I can teach someone in a year's fellowship here what it took me 25 years to learn by myself, on like the hard way, so it's exciting. It's an exciting time for refractive surgery.
So now the cherry on top, we are talking about Presbyond. Dan, Presbyond is a corneal refractive surgery technique for presbyopia. I want you to explain the principle behind this technique and what advantage do you see when compared to refractive lens exchange, clear lens exchange?
Right. Let's just say, yeah, I mean, let's be very specific. You said clear lens exchange. I want to just hammer that in a little bit. We mean no cataract, because if we have a cataract, then it's cataract surgery. But we're talking about, in other words, the management of presbyopia in the absence of cataract. Yeah. And of course, cataract is not just age dependent. There's other factors that cause cataract. But just because you're old doesn't mean you have a cataract either. So, my father was 74 when he had Presbyond. He still didn't have cataract. He had 2016 best corrected vision. He had one cataract done when he was 86 in one eye for 2025 cataract. So he died 3 years later without really having cataract. If you call 2025 not cataract, okay? So having said all that, Presbyond it's been much easier for me to explain Presbyond in the last couple of years than it used to be. And the reason for this is that the lens companies have finally, after 20 years of kind of, let's say, fighting against Presbyond and saying that clear lens exchange with a multifocal lens is better, they finally gave up. And what they're doing now is copying Presbyond. So that's why it's so easy for me to explain it now. Everyone now knows the acronym EDOF. Everyone knows that now. But that is exactly what Presbyond is. And that's what we've been doing since 2004, when Tim Archer and I developed it for the first time. It's EDOF in the cornea. And so by having EDOF in the cornea, you actually increase the depth of field of each eye, and therefore you don't have to do monovision anymore. Monovision is one eye for near, one eye for distance. It requires suppression for it to work. About 50% of humans can suppress fully and enjoy monovision, because when they look at distance, they completely suppress the other eye, and when they see up near, they completely suppress the distance eye. Problem with monovision is that you don't have good intermediate vision because, well, there's no EDOF. And so the early work that we were doing was, to try and bridge this gap in the intermediate range. If you reduce the anisometropia, you lose the near. So how do we get extended depth of field in the cornea so that because the question was, can we reduce the anisometropia so that almost anybody tolerates the difference? We all know, for example, that in cataract surgery, if you use monofocal lenses, you don't have to ask the patient anything, and you don't have to even explain to them that you're going to do one eye plano and one eye minus 0.75. You don't have to explain that. And actually, it doesn't even matter if you do the distance eye plano or the dominant eye plano or the non-dominant eye plano. Graham Barrett's shown that very elegantly. It doesn't matter which eye you're doing for distance. The first cataract, just do that one for near or do that one for distance, and then the second eye, even if it's the dominant eye, you do it for near. So 0.75 is tolerated by basically everybody. And so what we discovered after, some iterations was that when you set the eye to a nominal refraction of minus 150, the non-dominant eye, the distance vision of that eye with spherical aberration and minus 150 is actually 2060. Yeah, 618. The vision of a minus 0.75 eye is 618. So while the eye refracts to minus 150, at distance, it sees as if it was minus 0.75. That's the depth of field. But you see, it works in both directions. So the minus 150 eye sees at distance as if it's minus 0.75, but it sees it near as if it's minus 225, because there's a 1.5 diopter bracket of EDOF around that center of minus 150. So the distance vision is more than you'd expect, and the near vision is more than you'd expect. So in the end, actually, when you do Presbyond, it's actually not monovision, and it's not modified monovision. It's actually modified binocular vision. Because when you have 20/20 and 20/60, there's so much information, image information in the 20/60 eye, that actually there is complete fusion between the eyes, and there is no suppression. In that sense, you don't switch the eye off. The eye stays on all the time, and we know that because we've done all the stereo acuity testing after Presbyond, and we've found that everyone, patients they preserve stereo acuity, even though one eye is for distance. They still have stereo up close. They can't read with that distance eye anything bigger than J8, but there is enough information to get stereo acuity. So in a nutshell, Presbyond is what the lens companies are doing now, but we were doing it on the cornea 20 years ago. And that is using spherical aberration to increase the depth of field in each eye, to allow us to do a very small anisometropia in order that 95, 97% of humans can tolerate it. And it's done as a Lasik procedure, which is much safer than clear lens exchange and more accurate than clear lens exchange, probability of landing on target, and it's less side effects than clear lens exchange if using a diffractive multifocal, a diffractive lens, and it's adjustable, which a lens is not. A lens is adjustable by laser. So why don't you just start with laser then? Why start with a lens? Why start with a lens in a 55-year-old who still has 1.5 diopters of accommodation? You're taking that away like that. It's gone. You take it out, suck it out with the phaco machine. Now you're replacing it with a static system that has multifocality, rings and rings around lights at night. And I know your colleague in Brazil has developed a spiral optic lens that has less, disturbances, but it's still a multifocal. So it still has them. Whereas an eye that has EDOF from spherical aberration does not have them, does not have halos, doesn't. That's how it's designed. So in terms of visual quality, you can't match the use of spherical aberration when it gets completely filtered by the brain.
Then I just want to add something that is sometimes when I'm explaining for a patient that we are doing Lasik and Presbyond in their eyes, some of them they question me about like the how long is the procedure going to be good. I mean, for how long they are going to see up close, and this is actually something that I told them that the great news is that we can fine tune it in a few years if needed. So that's one of the good things about doing Presbyond or laser for presbyopia, and that is another thing. That is another advantage of doing LASIK, because when you have a flap, you can lift it and retouch it very easily. So, I mean, that is a great advantage of a laser procedure.
That's right, and which you can't do with SMILE. There's no enhancements with SMILE. But doing LASIK on top of SMILE is a great procedure. So that's a whole other thing that we talk about. But what you've said there is very, we can go back to the very first question that we were talking about, which is, why is PRK so popular in Brazil and not in, I don't know, the United States or England, or France or Spain or Germany? Well, it's because PRK is easier to do technically for the surgeon and doesn't require the expertise. And enhancements, you talked about lifting a flap, it frightens people because they get worried about ingrowth. And then they get worried about ingrowth that they can't manage. So it goes back to the first question, and I would say that, I maybe this is a bit rude, but if I have absolutely no fear of ingrowth. First of all, I know how to avoid it as much as possible. I have a technique for lifting flaps which gives me very low ingrowth rates that require treatment. And if it requires treatment, I know exactly what to do. So it doesn't create me any anxiety whatsoever to lift a flap and do an enhancement. Whereas if someone says, oh, but PRK is better because with the flap lift, it's like the people that do LASIK and then they say, oh, don't do a flap lift. Just do PRK on top of the flap. Why? Because you get ingrowth. It's like, oh, okay, this guy needs to take the course. Do you know what I'm saying? It is. I think I sound a bit rude, but I'm not trying to be rude. I'm trying to be helpful. I'm trying to point out that there is just no mystery behind refractive surgical techniques. There isn't anymore. There used to be 20 years ago. We used to sit around the table arguing with each other about, well, I do this and I do that, and my technique is this and my technique is that. And I like to believe that, like the airline industry, we need to standardize, and that there should be a standard technique which we know works. And that if you're starting refractive surgery, that is the technique you should be using. Like, do what works. You want to change it later? You want to be a scientist? Great. You want to be an artist? Knock yourself out. Do as much as you want. But if you're starting refractive surgery, why don't you start from a position where someone can actually tell you exactly how to do it and get great outcomes and low complication rates? Isn't that a good idea?
Now we have a question sent by Dr. Kobayashi about regression rates in Presbyond. Are they comparable to those seen in conventional hyperopic treatments? And in case of regression, how can we approach the situation then?
Sorry, is the question only about hyperopia?
He asked about the regression rates comparing Presbyond and conventional hyperopic treatments.
Right. So Presbyond, and for example, in our course, we don't just talk about Presbyond because we talk about all of the corneal techniques for presbyopia. Presbymax, supracore, inlays, we talk about everything because you have to like have the full picture here. The regression rates in Presbyond are identical to the regression rates of LASIK because it is just LASIK. Because it's not a multifocal cornea like Presbymax, like supracore, there is no complex epithelial healing. And so, whereas in those procedures you get regression of the effect, of the multifocal effect, because of epithelial remodeling over time, with Presbyond, it's just LASIK with a certain amount of spherical aberration either left in the cornea or put in the cornea. And so there is no difference. And so we all know that LASIK is a stable procedure. We all know that corneal refractive surgery is a stable procedure. So once you reach stability, I mean, there are a few studies now published, 20-year outcomes. And these are from the earliest patients that were treated in the late 1990s, which were the profiles with no transition zone and, spherical treatments, no asphericity, like the worst, like the best we had back then, which would be the worst now. And they show stability. So the answer to the question is the stability of Presbyond is the same as the stability of LASIK, not different. But he did mention something about hyperopia, and the stability of hyperopia corneal procedures depends entirely on the platform and the way that you program it. Because what we know now is that smaller optical zones, smaller than 6.5 millimeter zones, do not have good stability with hyperopic treatments. And the preferable optical zone is 7 millimeters. And the transition zone should be 2 millimeters. If it's any less, you get more regression and more scatter in the results. And we also know that in hyperopic treatments, when you want to do an enhancement, it's not the Ks that determines if you could do more steepening. It's the epithelial profile to find the minimum thickness of the epithelium over the steepened area of the center. If you're monitoring the epithelium after hyperopic corneal surgery, you can often do enhancements even if the cornea is already 49 or 50, if there is sufficient epithelial thickness to do so. You might also find a cornea that has a 42 diopter cornea where you can't do even a +1 because the epithelium is already too thin over the central steepened part. So, there's a paradigm shift in understanding about the safety of hyperopic corneal surgery is forget the Ks. It's about the epithelial profile. The epithelial profile is the thing that makes the difference, and the Ks was a proxy for the epithelial profile, which didn't work in many cases, and that's what scared people away from doing hyperopic corneal surgery. And so, we have published a paper on with more than, it's more than 600 eyes with hyperopia from +4 to +7 with 2-year outcome stability with 0.4% of eyes losing 2 lines, 0.4% losing 2 lines. That is lower than clear lens exchange. Clear lens exchange is about 2% loss of 2 lines. So again, evidence versus folklore, but also we're talking about technique, optimized technique. So even the best phacosurgeon on the planet is going to get 2 lines loss of best spectacle corrected vision with a clear lens exchange. And we can go into the reasons why, but those are the numbers. Whereas an expert at hyperopic LASIK will get 0.4% loss of 2 lines. And by the way, while we're on to this, to answer his question, if someone does hyperopic Presbyond, for example, or hyperopic monovision, or read with the Alcon system, which is approved for low hyperopia, if you do any of these treatments, none of which are multifocal corneas, but if you do these treatments and someone does develop a cataract later, it's beautiful because you use the Barrett TrueK-TK formula, you get very good accuracy, and you already have the EDOF on the cornea from your hyperopic treatment. So your monofocal IOL restores your presbyond, and you don't need to put in a multifocal. In fact, you shouldn't put in a multifocal because you don't need to split the light anymore. You've got the EDOF on the cornea. So, it's all a very happy circle of, family circle,
And you couldn't also tell which procedure was made between those 3 you said if you take a topography, because they very much look alike. I mean, they are all aspheric procedures. I mean, so you could expect the same regression rates between them. So if they are made with large optical zones, good transition zones. I can speak for myself. I have a 5-6 years patient follow-up here that I did the hyperopic treatments, Presbyond and aspheric treatments. And sometimes they indeed are more hyperopic, but their corneas, they look very much the same as 3 or 4 months post-op with 5 or 6 years post-op, because there wasn't any regression on the cornea. So that makes us think, is it a loss of accommodation? Is it because we didn't treat the whole hyperopia the patient had at the time? So yeah, I can speak for myself that I see that those corneas are very stable over time.
Yeah, that's right.
It's very good to know because I had hyperopic LASIK in myself 6 months ago, so I need this stability over time. So I'm very happy with your considerations. Now to sum up, I want to know more about the course. Then you will be teaching a course in São Paulo in August, and I want to know about the topics covered, the format, and also if you can explain people how to register in course. We are going to include the registration link in the podcast description as well. So
yes, and I welcome everyone to come. In fact, residents. This course is designed so that if you're a resident in ophthalmology, you will get a ton out of it. If you're someone who's done 15,000 eyes as a refractive surgeon, you'll still get a ton out of it. Because what we're doing is we're covering each subject with the evidence base behind each area, so that we're not just learning rules, we're learning the source information so that you can then remember everything more easily. And so the format of the course, the first day is basically expert LASIK technique. Of course, I'm talking about surface procedures as well, but we're talking about expert LASIK technique. We're talking about how to perform a perfect LASIK procedure instruction book, so that if you take the handout and you follow those things exactly, you will be a perfect LASIK surgeon. You will. There is no, as people say, oh, he will, I'm not going to tell you my secrets. It's like, no, I'm going to tell you everything. Like, I'm going to tell you everything I know, because I want you to copy me. And by the way, if you can do something better than me, great. I will copy you, and then you're not better than me. So that's how you stay at the top. You keep on copying people that do stuff that's better than you, and then you eventually are doing everything right. So the first day, super expert LASIK technique, how to do the perfect LASIK procedure, how to put a flap back, how to manage microfolds if you see them in other people's flaps, because you're not going to have any, and then how to do an enhancement, how to manage epithelial ingrowth, everything, And then we're going to talk about surface procedures, because they do have a place in refractive surgery that's very important, even in my practice. But we do very little of it, because we do it when it's indicated. So that's basically your sort of like basic refractive surgery and expert refractive surgery all in one day. The second day is presbyopia. And so we're going to talk about all options. We're going to talk about how to approach presbyopia in the absence of cataract, of course. And we're going to talk about the theory behind multifocality, EDOF, so that everyone understands where this is all coming from, the advantages, the disadvantages, because you have to have the LASIK and PRK knowledge already, because if you don't have that, you can't do corneal surgery for presbyopia. So that's why we introduced that day as well. And then we also include at the end of that day, we talk about a sort of lifetime plan. How do you plan for a lifetime? A patient comes to you at 18 for their first procedure. What happens next? What happens next? You keep people out of glasses the whole of their lives, usually just by laser or lens and laser, like an ICL plus laser by optics, or lens surgery, depending on what's required later on in life. The third day is the dedicated lenticular surgery day. So it doesn't matter if you're using a Schwinn platform or you're using any platform. It's about lenticle extraction. It's about how to optimize lenticle removal, centration, cyclotorsion, docking, and then we have the standardized technique for removing the lenticle, and then we have the non-standard ways. In other words, people call that complications, but I don't. I had Monday. I'm a very experienced. I've done more than 10,000 smile procedures, but I had a severed lenticle. It was a difficult dissection, and I thought I got the whole thing, but of course, protocol is to check the lenticle on the surface of the cornea, which I did. I've done that for 10,000 eyes. I've never not checked a lenticle. And I found that I left a crescent in there. But again, zero panic, because as we describe in our textbook, there are 4 techniques for finding the remnant. And I started with this, I did that, I ended up using that. I found the lenticle, I extracted it, I put them back together like a little puzzle on top of the cornea. It looks beautiful. The patient was seeing better out of that eye this morning than the other eye that was routine. In other words, it doesn't change the outcome even if you have a complication, as long as you know how to manage it, right? So we're doing lenticle procedures, and that's basically it. I mean, what can you say? I mean, after that, if you know all of that, you're ready. I mean, the only thing left after that is therapeutic refractive surgery, but that's a separate thing. And for example, we have a therapeutic refractive surgery course once a year. In November in London, and we require people to take our first course before they come to the second course. I don't care. It doesn't matter how experienced someone is. they have to come to the first course, because a lot of people come with questions about this. And I'm like, well, that is in the first course because it's microfolds or centration or this, so, we have to build on knowledge. You can't just jump into, how do you do a topography guided treatment for decentration? You can't just jump there. You have to know everything to get there. So that's not this course, although we will talk a lot about what people call complications. We just call it non-routine ways of finishing the surgery. Complication, in our definition, is the patient leaves the operating room and has a problem with their vision. That's a complication. You have to bring them back and do something about it. But intraoperative complications and immediate post-op complications, we deal with all of that because that's part of the primary procedure. So essentially, I would really hope that lots of people will come, because Fauze, you'd be better at describing this than me. But you said what you said. I mean, the reviews that we get at the end of this course, we've been teaching it for 10 years, are the first time we taught this, we kept on getting these reviews that say, this is the best course I've ever attended in the entire career of medical school. I've never been to any lecture or any course with this level of detail. And when we first got those reviews, Tim and I and Glenn, we were like, wow, that's amazing, incredible. And then the thing is, we keep on getting that review. And now when we get that review, we look at it and we go, yeah, another one of those, And I wish it wasn't like, I honestly wish it wasn't like that. I wish all courses had this level of granular detail and evidence-based, and not my technique is this, but the technique for doing this is this. And that we standardize refractive surgery like the airline industry standardizes how to fly an Airbus 320. You can't fly an Airbus 320 just because you bought it. You can't fly it the way you want to. You got to fly it the way it says in the manual. And this is what's missing from refractive surgery, is that everyone can buy a laser, but they're not obliged to do it in a way that is guaranteed to be the optimal way to make it, or the optimal chance of success. So we get a bad reputation in refractive surgery because the very few people who have complications, it breaks my heart, but I mean, most of those patients have preventable complications or fixable complications. I would say more than 99% of the people on the internet unhappy with their refractive surgery are fixable. It's just that they don't have access to a surgeon who has access to the knowledge to fix it. Or, maybe they don't want to fix it, or they don't have the technology to fix it. I mean, if you're using an older Vizix laser, you can't do topography guided treatment, so you can't fix it. You just can't, right? So this is where the field of refractive surgery, I mean, if I just tilt my camera here, there's a big certificate at the top up here. Where am I? There, that one. That's the World College of Refractive Surgery. And the point of the World College of Refractive Surgery is to standardize. In other words, to set up a minimum standard, so that if you see that badge on the website of that surgeon, the public, the patient will know that that surgeon at least has the minimum standard. And this is where we need to go with refractive surgery. This is where we need to go, so that the most common cause of visual impairment in the world, which is refractive error that is not corrected, it's about 50% of visual impairment on the planet is because of uncorrected refractive error. And it's uncorrected because people can either not afford glasses, or they don't have access to glasses, or they got a pair of glasses and they lost them and they can't get them again. I just came back from Ethiopia last week, and one of the patients that I operated on, was bullied in school. He was -8. He was bullied in school. He didn't really finish school. He became a construction worker. He's 38 years old, and he, is just, not great. And I said, well, he said, why are you here? He says, well, because I broke my glasses. I said, well, how many months' salary does it cost you? What proportion of your monthly salary would it cost you to buy a new pair of glasses? And he said, it would cost me 3 months' salary. So you understand why a lot of people are blind for a stupid reason. They can't afford glasses. Whereas refractive surgery, as we brought it to Nepal 12 years ago with Kishore Pradhan, and we're now bringing it to Ethiopia, the idea is that if you can have a system where the lasers are funded and you have a cost recovery model where the people who can afford refractive surgery pay for it and the profits are recycled into treating people who can't afford it, you can actually, the actual raw cost of doing a refractive surgery procedure is relatively low. The real cost is the laser to buy it. It's $500,000, for each laser. So it's a lot of money. So in that sense, you can't help people like that. But if that is already paid for, then you can help people because the base costs are rather low comparatively. In fact, the base costs of refractive surgery are similar to the cost of one pair of glasses for high myopia. It makes sense. So anyway, we get into philosophy here.
No, but this is a really important project. Congratulations for them. Fauze, do you want to add something?
Only some final words. I second Dan about his course because it was indeed a game changer for me. I mean, it gave me a lot of confidence for doing better LASIK, but also to do better, I mean, not advanced, but to do something that others weren't doing and to separate myself from others refractive surgeons, which gave me a lot of projection here. So yeah, I think everyone should do it because if you want to be a better refractive surgeon, this is the way to be. I mean, you not only have access to planning, but also execution. So that's why it's so worth it. So yeah, I hope to see you guys in a couple of weeks.
It's taking place in August 16 in São Paulo. For those who are interested in attending, the link is in the description of this episode. It also has special prices for ophthalmologists in training, residents, and also fellows. So it's really nice. I want to thank Dan and Fauze for this conversation. It was a pleasure to have you here with us. And I want to thank ZEISS for their support. This is the OFT-CAST. Till next week.